Hi, everybody. How are you today? Good. So let me see if I've got how this works here. All right, excellent. So first of all, thanks for the nice introduction. That was a wonderful talk. I don't think that I knew how much I truly loved spaghetti until I just heard that it's my favorite food, but now I like it even more because we can relate it to the spinal cord. So I'm a neuroimmunologist and neurologist here in Columbus, Ohio at the Ohio Health MS Center. And I just want to thank the Transverse Myelitis Association for giving me the opportunity to come here today and meet all of you and talk about what I think is one of the most disabling symptoms of myelitis and many of our neuroimmune diseases. So it's an important issue. Obviously, pain matters because it hurts and it gets in the way of our life. But I think most importantly, what my patients who experience neuropathic pain share is that they just want to go out and have fun. They want to be social, or they want to interact with their kids or their family. And when it hurts so much, it really limits that, and it limits your ability to enjoy life. And the challenges that were already mentioned by our other colleagues today about fatigue are something that we face a great deal when we're trying to treat neuropathic pain, because most of the medications that we use to reduce pain actually make you sleepy. So it's a bit of a vicious cycle. And then, of course, pain keeps you awake, because if you're hurting, then you can't sleep very well. I think it's important also, as mentioned earlier today, that we address the psychological factors of what we deal with, not only as just being normal humans, but also as people living with a disease or being debilitated from a neurological disease. And so it's very important when we're looking at somebody that has neuropathic pain that we also assess how the mood is. That's the number one question that I always ask in clinic, because if mood isn't being addressed, if somebody feels depressed or anxious, that actually heightens all of the symptoms that you have. It can make your pain worse. Interestingly, there are lots of treatment options that can actually not only address mood, but also help for pain. So sometimes we try to use something that knocks out, we use one stone to kill a few birds, I'd say. And then certainly pain has a significant physical burden, and we'll talk a little bit more about that. So I put these pictures up here because I think sometimes when we talk about pain associated with myelitis, people think, oh yeah, I've had a pain before. But I don't think most people who haven't experienced these diseases know what it feels like to walk on fire. And I really have folks who come into my clinic and tell me that's what they feel like when we talk about the character of the pain. Or even they feel like something's crawling all over them, or it's like somebody's sticking tacks into their feet. And so this is pretty unbearable, but I think it's always important that if you are experiencing pain and you're sharing that with your doctor or your nurse practitioner, tell them what it feels like, where it is, how often it happens, how long it lasts, because that often impacts the treatment choice that we're going to offer to you. I know today earlier there was a discussion on spasticity, and I included a little bit of that in this talk because it also is very relevant to the discussion of pain. I want you guys to raise your right hand, and I want you to squeeze your fist really, really tightly, okay? Now I want you to hold it like that for the rest of the symposium and tell me how good your hand feels. No, really. So I use that technique when I'm talking to medical students and residents to try to teach them about the pain associated with these diseases, because unless you've experienced it, it's really hard to understand from a textbook. So I like this figure because it encompasses a lot of the different types of pain that can be experienced when you've had damage to the somatosensory pathways of the spinal cord or also the brain. There's commonly described as a Lermite's phenomenon. So if you've had spinal cord inflammation or spinal cord damage and you flex your chin to your chest, not only is that a hard stretch for a lot of us if we have a bad pillow or didn't sleep well, but also it can send a shooting electric shock-like pain down the back. And that can be one of the most disabling pains. I have a lot of people who tell me that, and they say, well, the last neurologist told me don't do that. How hard is it to live your life walking around not bending your chin down or looking down? So we need to know about what symptoms you're experiencing so we can address them. Certainly prickling pain, tingling, pins and needles, or a tightening feeling that often comes from muscle spasms. So when you hear the term neuropathic pain, that's just a fancy neurologist word that just means that it's pain caused by damage somewhere in the nervous system. So there's two main types. There's the peripheral nervous system where we have our branching nerves that go out to the skin, the nerve roots that come off of the spinal cord. But then in most of our rare neuroimmune diseases that we've discussed at the symposium, this is central neuropathic pain, typically caused by damage to lesions within the spinal cord or the brain. In the brain, there's a pathway that mostly encompasses the cortex or the somatosensory cortex, and then also a structure called the thalamus. And so when there's damage there, that can cause significant pain. And then certainly in the spinal cord, there are a number of areas that can be interrupted. And I promise you, I'm not going to get all sciencey as our last doctor up here mentioned. But I think this picture is helpful to understand why some people experience numbness, sensory loss, or pain so differently. I don't think that I have a pointer up here, but if you look, you can see the pictures above the people in this diagram, and that picture is a cross-section of the spinal cord. Oh, thank you. Somebody reminded me that I have a mouse. So if you look here, this is your classic transverse myelitis, where you've had an inflammation that goes across the spinal cord. In the posterior part of the spinal cord, there's a pathway called the dorsal columns, or if you want to be fancy, it's the dorsal column medial lemniscus pathway. But that is where your vibratory sense, so have you had a doctor hit a tuning fork and put it on your toe? If you haven't, you need to find a new doctor. But the other thing is if they wiggle your big toe to point it up or down. And the reason they're doing these silly tests is because they want to know what part of your nervous system is affected. When I move your toe up and down, if you can't tell me whether it's going up or whether it's going down, that's really important because that means without looking at your feet, you don't know where you are in space, and that can be dangerous. You know, when you close your eyes in the shower and you can't feel where you are. So that means you've had an interruption of that pathway. When we look at the more ventral portion or the anterior portion of the spinal cord, the major pathway is something called the spinothalamic pathway. And that's where pain, temperature, and light touch can be changed. So if you've had inflammation that goes in that area, that's where you can feel some painful burning sensations, or you can feel like you're numb and you don't have any sensation at all. Or you might say that, gosh, I get in a shower and the water's warm, but it feels cold to me. Or I just feel like I'm always cold all the time, but if you touch my leg, it's warm. So this helps to explain a little bit of that and why it can be so variable based on where the inflammation has been in the spinal cord. So I want to go through some definitions, and certainly you don't have to memorize all of these, but sometimes it helps to better understand why you have these weird feelings. So spontaneous pain can be common, where it just comes out of nowhere and you have sharp stabbing pains. Certainly allodynia is incredibly common in these disorders. And that's when you might say, gosh, I put my hand on my significant other's leg just to provide comfort, and they say it hurts. They won't even let me touch their leg. And that's allodynia, where a stimulus that shouldn't induce pain actually causes pain. There's another sensation called hyperalgesia, and that's when you have an increased response to a painful stimulus. So it's significantly heightened. Or sometimes we call that a dysesthesia, just an unpleasant sensation that we're not supposed to experience. So if somebody touches you and you feel it as painful when it shouldn't be painful. And then sometimes in neurology we use a non-specific term called paresthesia, when you just have those strange sensations that sort of come and go, and you might feel it as a tingling, or you feel like things are crawling on your skin. And then there's a few more. So hypoesthesia, where it's a decreased sensation. Anesthesia, certainly a complete loss. Hypoalgesia, decreased pain, that can be dangerous. So if you can't feel your feet, I had a patient who had a transverse myelitis, and he, unfortunately, one day when it was very hot outside, didn't have his shoes on. And he went and he walked across the blacktop, and he burnt the bottoms of his feet because he couldn't feel the bottoms of his feet. And so it's really important that if you have these symptoms, we know about it so we can protect you from the consequences of not being able to feel, because sensation is actually very, very important to protect us in life. So I'm going to go ahead and move forward here. Again, I don't want to belabor the point on spasticity because I know that you guys talked quite a bit about it earlier today, but sometimes people don't understand what that means. That can be incredibly painful. It's surprising how many times in neurology I hear people say that these diseases don't cause pain. I think they're some of the most painful diseases that we see in neurology, but people describe it as having cramping or spasms or tightness and impairing function. So I think it's important to also figure out when you do have pain, where is it coming from? Is it the nerve or is it the muscle? Because we treat those differently. Again, this can be mild to severe, and there are many different ways that we address it. But again, as we talk about all these symptoms, I want to say that the good news is there are options to help. I think that we need a lot of improvement from where we are right now, but there are ways to treat this. This is, again, is just a summary slide describing what causes spasticity, but it has to be damaged somewhere in the brain or the spinal cord, and there are a number of neurologic conditions that can cause this problem. I put some pictures up here because one of the challenges is if you have pain related to spasticity, we certainly want to treat it, and not only do we want to do exercises with stretching and also treatments to relax muscles, because we don't want people's limbs or arms or hands to get stuck in a position where they can't move. And so oftentimes in my clinic, I'll see people where they never really knew that it was something to be addressed, and their arm or their fingers will get stuck like this, and then it can be very challenging to address that and alleviate the pain caused by that. So how do we decide on a treatment plan? Definitely when you come in, it is important to know you, to know what happened, what part of the brain or the spinal cord is affected, and what time of day do you have your symptoms, and also where in your body are the symptoms and what do they feel like. So we don't just throw, the same medicine at everybody, although I would say most people would say, yep, you do, everybody gives me gabapentin. And that's a really common one, but there are a lot of options. I think the most important thing, as I alluded to earlier, is making sure that when you have neuropathic pain or spasticity, that we understand what are your other medical problems that you're dealing with. As I mentioned earlier, if you have depression and you have fatigue and you have neuropathic pain, maybe we're going to try to use a medicine that targets all of those issues. So there are some antidepressants like duloxetine, which can treat pain, and it can also improve energy and treat depression as well, or anxiety. So we want to try to use things that make sense, not giving you one pill for every single ill that you have, so that you have a really long medication list. We also want to talk about what benefits. So I think it's a lot of the time the expectation if somebody gives you a medicine is that it's going to fix it or make it better. And so a lot of times that initial plan is that we just want to reduce the pain somewhat. So even if we get a 20% benefit, that's good. We may be able to push the medicine up a bit, or maybe we're going to have to add in another type of treatment modality. I think the side effects are also important. So as mentioned earlier, it's not very good if we're treating your pain but you sleep all day. That's not really any life to lead. So sometimes if there's a medicine that's benefiting you, let's say like the gabapentin example for instance, but it makes you sleepy, maybe we'll just dose it at bedtime to help you sleep through the night and then wake up in the morning, and there may be other things that can be done during the day. And then certainly the mode of administration. Some people are tired of taking pills or don't want to take another pill. There are different types of creams and sometimes injections that can be used depending on the type of pain. So definitely ask your doctor about that. So this is just an overview of some common first-line treatments that are used in neuropathic pain. So we mentioned earlier the gabapentin and the pregabalin. Those actually act right along the pain receptor pathway to block voltage-gated calcium channels to reduce pain. But again, the side effects of those medications certainly can be if they're given at too high of a dose too quickly, they can make people sleepy. I've listed here a couple of serotonin and norepinephrine reuptake inhibitors, and these are medications that are used to treat depression and anxiety, but can also reduce neuropathic pain, so duloxetine and venlafaxine. When we look at the TCA category, those are tricyclic antidepressants. These are medications that neurologists have used for a very long time to treat neuropathic pain. Another one that's not up there is something called amitriptyline. Those are medicines that we traditionally dose at bedtime to help you get a more restful sleep, but to also reduce pain. But again, I have to be clear that when people take these medicines, they have to start at a low dose and slowly increase up to prevent having significant side effects. Sometimes topical creams like lidocaine can help, and there are other ways. So a lot of us in neurology will call in prescriptions to compounding pharmacies where we can combine some of the medications that you might take orally, but have them crushed and made into a cream so that you can put them on the area of your body that's painful. That can be quite a challenge if you have pain and numbness, from the chest down. So again, we have to look and see where your pain is and what the options are. And then aside from the topical lidocaine patches, again, there are creams. And then I put up here just some other common treatments that are often used. So many times we find benefit with anti-epileptics or anti-seizure medicines. Carbamazepine or oxcarbamazepine, these are medications that if anybody here has ever had something called trigeminal neuralgia, which is a sharp shooting pain along the face, that can be very beneficial, but I've also seen it be beneficial when people have pain from myelitis, or if anybody's ever had what's called a dystonic spasm type pain, where one half of the body kind of crunches up and spasms and gets very tight. Those can be incredibly effective. Also, capsaicin cream for some people. Again, we talked about the compounded pain cream. And then for spasticity, muscle relaxers like baclofen and tizanidine, again, being careful not to make somebody overly tired. And botulinum toxin injections can certainly help for spasticity, and I have used them for individuals who experience hug-like sensations around their body from a myelitis. And then again, coming into recent times, we need a lot more data on this, but some suggestion that cannabinoids may be of benefit here. Certainly we can't forget other treatments that should always be incorporated in this disease. So earlier we talked about physical therapy, massage, acupuncture, meditation, mindfulness, exercise. Anything that you do to keep your body moving is going to be important, is going to help you feel better because it feeds back into the cycle of improving mood, improving function, and reducing pain. Sometimes counseling and biofeedback. I know the speaker after me is going to address some newer options for pain treatment. There's another therapy called scrambler therapy that some of you may be aware of, but this is a treatment where they hook up electrodes to your skin and actually send signals, electrical signals to the nerves to try to provide less painful signals along the nerve pathway rather than the painful signals that you experience after a myelitis or an inflammatory disease causes damage. So again, if you have symptoms of nerve pain or spasticity, please talk to your neurologist or your care provider. Bring up the symptoms, make sure they know they're important. It's very, very important if you have seen many doctors, keep a list of what worked for you or what didn't work for you, because it's hard if you don't remember and then maybe you have to go through some of the same treatments to tell them, hey, that didn't work again and you just gave it to me a second time. Also, they can share with you the research on alternative options as well. And then there are many trusted resources for information. I included some of those up here, but the nice thing about online is there are many great resources. Just be careful what you read and that it's a trusted resource. Overall, the goals here are to reduce your pain, improve activities of daily living. We want you to have an excellent quality of life. We want you to be able to sleep, and to reduce anxiety and depression, and to just live. So these are the take-home points, and I understand that we're short for time, so I'm going to stop there, and then if you have questions, please find me after. Thank you.